we shall do our presentation for the next 1 hour or less. And then if you have any issues or any questions, you are free to write on the Q&A. And when you want, sometimes there are a lot of comments on the general chat. So ensure you just send the question to moderators. There's a way when you're writing, you can send to hosts and panelists. So just send to hosts and panelists so that we're able to filter from the rest. Again, you don't need to write your name to confirm your attendance. Our system automatically picks your attendance. And as I'd said that in the previous webinar, some of you received certificates that were written their fonts names. So ensure that when you're logging in onto Zoom, you have used your full names as you'd want them to appear on the certificate. Again, this session or this webinar is KMLTB approved, and as a result, it shall attract three CPD points. So that CPD points ensure that you just listen in. We want you to be here for at least 50% and ensure that you have paid. And for those who have not paid, for us, you can still join and pay later. You can pay after the session. And if at all, maybe you are busy at this time, this session is going to be recorded and shall be available on our platforms. That means that you can still watch up to tomorrow by 12 p.m. and you shall still be awarded a certificate. So with that, our certificates take a maximum of 3 days. Though immediately after the presentation, you shall be able to start seeing them streaming into your emails, but be patient until the lapse of 3 days. With that, allow me to introduce to us our today's presenter, who is Dr. Rogers Norman Demba. Dr. Norman Rogers Demba has many years of experience in medical lab science. It's not new. He holds a Bachelor of Science in Medical Laboratory Science from JKUAT. He also holds a Master of Science in Virology from JKUAT. And also he holds a Master of Business Administration, Strategic Management from Kenyatta University. Dr. Rogers also holds a Master of Public Health in Epidemiology and Population Health from Maseno University. And also Dr. Rogers Norman also holds a Doctor of Philosophy degree in Tropical and Infectious Diseases from the University of Nairobi. And currently is the chairman of the Medical Laboratory Sciences at Maseno University, which is housed at the School of Medicine. So with that, welcome Dr. Rogers, and you can proceed.
Yeah, thank you so much for that introduction. Allow me to share my slides. I don't know if they are able to see my slides. Everyone able to see my slides?
We are able to see. Just go to
presentation mode. Thank you so much. I want to first apologize. I'm in Kisumu, and where I live, I'm currently experiencing blackout, but I want to believe that this will be successful. So I'll go straight to the title of my today's presentation. I gave it, or I coined it, a cross-sex laboratory and clinical insight into HPV co-infection in advanced HIV. The reason why I focused on the cross-sex aspect is because a lot of emphasis and awareness on HPV, that is human papillomavirus infection, has been put on females or the girl child. A lot of attention has not been given to the males, but there is need for scientists to be aware that even the males can have this infection. And as we'll see in my presentation, I'm going to give a brief presentation on that. So I've also emphasized the aspect of co-infection in HIV, and with particular focus on advanced stage of HIV, and we're going to look into that. So on to my introduction. I've introduced this by sharing with members that indeed these two viral infections can occur as a co-infection. And in the event that this happens, then the patient is more likely to have a more aggressive form of HPV. Why is that so? Because we know very well that HIV, by its name, human immunodeficiency, the virus has a tendency of compromising the immune system of the people who are infected with it. So you can imagine a situation where one is already exposed to human papillomavirus, and your immune system is already compromised by the virus that is HIV, then what is likely to be the outcome is the more aggressive form of human papillomavirus infection. One thing that we also need to be cognizant of, that human papillomavirus come in two different types, that we have the oncogenic type and the non-oncogenic type. The oncogenic type associated with high risk genotypes, that is 16 and 18, that is very, very common both in males and females, but is well manifested in females as cervical cancer. Then we have the non-oncogenic type, which is associated with genotype 6 and 11. And here we have the genital warts, which can be seen in both males and females. So in the event that one has HIV and the disease progresses to a state or a stage referred to as advanced stage, here, the advanced stage here is classified based on the CD4 cell count. The CD4 cell count below 200 means that this individual is in a very advanced stage. What happens in the event that you are co-infected with HIV and HPV? Your immune system has been compromised, and females who have this HIV are 5 times more likely to develop cervical cancer than those who are HIV negative. What, again, you should know is that HPV virus, exposure to the virus does not necessarily mean that you'll turn out to have cervical cancer. It's not a guarantee. Why? Because an individual who has immune system that is well developed, who is not in a state of immunocompromisation due to one or another, it could be HIV or any other agent, is able to clear the HPV virus within a period of 1 to 2 years. But in the event that you have HIV, remember your immunity is going to be compromised and you will not be able to recognize the HPV as a foreign. As a result, it will be persistent in this circulation and the body will not be able to eliminate it. And due to that persistent occurrence and with the advancement of HIV, then the HPV, even if it was in a latent state, it becomes reactivated. So it's very, very important to understand that cross-sex understanding that is affecting both males and female is important. Why? Because there is need for targeted intervention for both males and females. So let's look at the anatomical differences that pose as a risk factor for both for the genders, that is males and females. We know for a fact that females have the cervix. So once one is exposed to this HPV, in the cervix region, it begins by forming what is known as the cervix interepithelial neoplasia. These are precancerous cells, and usually they can lead and develop and progress to form as cancerous form, depending on the stage. We're going to look at the parameter stage for cervical intraepithelial neoplasia. Males, on the other hand, it begins by forming precancerous condition. We have what we call the anal intraepithelial neoplasia. That is the precancerous form, and this can progress to form the anal cancer, penile cancer, oropharyngeal cancer. One thing you should know that the males is very common among the gay or men who have sex with men. So variability in immune response is very, very important. Imagine a situation where you are a female, you are constantly exposed to one sexual partner who already is exposed to HPV, high risk. So you continuously have unprotected sex with that individual. Then you're also exposed to HIV. Then that means that clearing this HPV from the system is going to be an uphill task. So there is need to be cognizant that variability in immune response also plays a key role in people who are already exposed to HPV. Because of that, tailored interventions can be made for both genders. We now have HPV vaccine that is being administered to both boy child and the girl child. And these vaccines are targeted age 9 to 14 years of age before they engage in sexual activity. We're going to look at the types of the HPV vaccines and the genotype that they protect against. So it's important, again, as a laboratory officers, to understand the pathophysiological interaction or intersections that occurs between HIV and this HPV. So I said in my introductory statement that the fact that one is exposed to HPV genotypes, whether it's high risk or low risk, does not mean that one will have cancer. The body has a way of eliminating or removing this from the system. Within 1 to 2 years, you can't remove it if your immune system is okay. But in the event that you're immunocompromised, what will happen here is your T helper cell 1 will be compromised and you'll not be able to recognize HPV as a foreign. So that means that there's this regulation of cytokines in the environment, and the persistent or the HPV that was initially latent becomes reactivated, and this increases the replication of the HPV and also increases the expression of the oncogene that is associated with the HPV. Gender-specific pathophysiology is important. We know that for females, they have the cervix, and for male, this HPV is known to cause the anal cancer or the penile cancer. So that aspect of physiology is very important so that we be cognizant. But for females, it begins from the cervix region as it progresses from a precancerous cell to a cancerous cell. And we're going to look into the other parameter of how this progresses. For male, for those who have sex among males, males with males, then we'll have the anal intraepithelial neoplasia, which is a precancerous, and this progresses to form an anal cancer, penile cancer, and also, and then it's worsened with those that are already exposed to HIV and are immunocompromised. In government today, the MOH guideline for screening of HPV or involves the use of via villi. Via villi is more cheaper. It means visual inspection using acetic acid or visual inspection using Lugos iodine. This is a very short timed procedure, usually done by the nurses. What it means here is a procedure that takes around 3 to 5 minutes. It doesn't confirm cervical cancer. It just indicates or shows that there is presence of abnormal cells in the cervix region. So these are a testing that is done as a screening test that is usually done by the nurses. What they do here is that they take, if they go the via way, that is the visual inspection with acetic acid, then you smear the acetic acid around the cervix region, then you observe for color change, okay? If it's acetic acid, the aceto-white presence is an indication that there's presence of abnormal cell. So what happens here, we can also do a colposcopy can be done, and this can be done by a qualified clinical officer, a qualified MO, a qualified gynecologist can do this just to examine the cervix so that you're able to also take photos and to see how maybe the cervix is intact or not. So the purpose of this slide is just for you to appreciate that we have rapid screening method, and this takes a very short period of time, and this is not a confirmatory test. So below here, you'll see a picture of the cervix, and there's some grading here, C1, C2, C3, okay? The C1 is a mild form, C2 is a moderate, and C3 is severe form. We're going to look into details about that in the subsequent slides. So for us in the laboratory officers, for those who have trained in cytology, those who have trained in histology, then this slide will be of interest to you. If you look at the first slide here, the A, B, C, D, E, this is a pap smear, okay? Mostly reported by cytologists. The one written labeled F, G, H, okay, up to J, this is a biopsy. I want to point out that biopsy is the gold standard for diagnosis of cervical cancer. And I also want to point out that there's a difference between having the presence of the genotype and a patient confirmed to have cervical cancer. You can only confirm if a patient has cervical cancer or anal cancer by biopsy. The genotype is not sufficient to confirm whether one has cancer. I want to repeat that. The only way to confirm whether one has cancer is by biopsy. This can be obtained from the cervix or from the penile region. So allow me just to take you through this slide. The one on the pap smear, A, B, C, D, E. Okay, the 1A is a normal, that is a normal pap smear with cells. If you want to report this, you look at the nucleus cytoplasmic ratio. That's one of the ways of reporting the pap smear. Again, you look at the pigmentation, okay? That is the way the cells are taking the chromatic staining method. So as you look at this slide, I've put for every slide, I've put normal for pap smear, for cytology, normal for biopsy below it, okay? So during the order parameter, that helps to establish the progression of this cervical disease. So we have what known as the cervical, the cervical interepithelial neoplasia 1, this region, or the low, that is the cervical interepithelial neoplasia 1 is grading by use of biopsy. And when you want to use the pap smear, you use the low squamous cell interepithelial lesions. So for cytology, you use squamous cells, but for biopsy, use the cervical cells, okay? So this is an indication of progression of the disease. It moves, okay, depending on the severeness of the exposure to that virus. So the key thing to look at is that as it moves from CIN1 or from low-grade squamous epithelial, interepithelial lesions to high-grade or CIN2, it means there's progression. The body was not able to clear it from the system. The virus has persisted, and usually it worsens when one has been exposed to maybe HIV, or those who also smoke is also a risk factor to enhance that progression. So we have the CIN1, CIN2. I want to point out that the fact that a patient has been confirmed to have CIN2 or even 3, 1 is a mild, 2 is moderate, 3 is severe form. That still does not confirm that the patient has cancer. And here, the treatment that is usually administered to these patients will vary depending on whether one has CIN1, CIN2, and CIN3. This can be treated even by excision, surgical procedure, and this does not confirm that one has cervical cancer. But in the event, let me proceed to the next, this other side. In the event that there's invasion of the basement membrane, are you seeing this membrane here? If the virus is able to penetrate and break the barrier of this basement membrane, then that means that now the virus has been able to invade the underlying epithelial tissues or connective tissues, and this is a confirmatory that this patient is indeed now having the cancer. And again, the treatment here is totally different. If you look at again in the cytology interpretation here, on the low grade here, you'll see there is some hollow clearing around the nucleus. But as it progresses, this diminishes. The cells are also increasing in number. They take more than 2/4 of the cervical region. So the barrier, basement barrier, once that has been breached, then that means that that is a confirmed case of cervical cancer, if it is a cervix, and the virus can metastasize. It can spread into the vagina, into the bladder, into the uterus. So for males, what happens in males? We have what known as the high grade and low grade, okay? We have the low grade penile interepithelial neoplasia, and usually this is common with low risk genotypes, that is genotype 6 and 11. Then we have the high grade penile interepithelial neoplasia. Again, this is common with high risk genotypes, that is 16. Then we also have the lichen sclerosis. This is not HPV associated, but it is a risk factor of HPV. So males will have penile cancer. Again, it progresses from having a precancerous cells to invasion, just like in females. And that can be presented in the form of penile cancer. And these are some of the pictorials. They could be a bit horrifying, but that it is what it is. So in the laboratory, besides doing this, the VIA-VILI, which can be done by the nurses, the screening that is using a pap smear, the gold standard I mentioned is biopsy. And also we have the genotypic testing to determine the presence or absence of high-risk genotypes. We have the biomarkers that can be used in the diagnosis of this HPV. One is by use of DNA diagnostic method, and this can help us to establish whether one is already exposed to high-risk genotype, that is 16, 18, 31. We can also use other biomarkers, and biomarkers, for me, I usually emphasize, if you're getting a biomarker, you need to know whether this biomarker, is it a diagnostic type? Is it a predictive type of a biomarker? So that is very, very important. So we have a biomarker that is HPV mRNA that is targeting the E6 and E7. It's both diagnostic and predictive. It's mostly used to indicate an active form of oncogene expression. If it is diagnostic, if it is predictive, then it's used to determine if the infection is likely to cause cellular changes. We have other biomarkers like protein 16 internuclear, K4A, which is also both diagnostic and predictive. Though not locally available, most facilities do not go this direction to use some of these biomarkers. In terms of treatment, antiretroviral drugs should not be delayed, even if one is undergoing cancer treatment. Why should that be so? Because the ARVs will help to restore the immune system or the immune function so that one does not progress to a state of advanced state of HIV. Because again, the ARVs will help to improve the tolerance and also response to this cancer treatment that is being used against HPV. The ARVs again will reduce the risk of opportunistic infection because, when you progresses to advanced HIV state, then one is vulnerable to opportunistic infections, and this can even worsen this outcome of the patient. Again, the importance of not delaying ARVs is that lower HPV persistence and also recurrence. Remember, I said that if your immune system is good, then the body will be able to clear or remove the HPV from the system. And also, if your immune system is good, it will help to recognize it as foreign and also prevent the recurrence risk. Treatment, again, HPV-related cancer treatment depends on the type of cancer, the stage. Remember, we talked about the CIN1, CIN2, CIN3, the high grade and for men and the low grade for men. Again, the treatment will depend on the stage and also on the type of cancer. Okay, we talk about the cervical cancer in females, the anal cancer cut across both males and females, because we know there are also males who prefer having anal sex with females. Treatment generally safe to administer with ARTs, that is antiretroviral treatments, although drug-to-drug interaction can be observed, but this can be managed by physicians based on the appropriate ARG regimen. To what extent do we have exceptions or special situations where you may want to withhold treatment? When the patient has a CD4 count of below 50, this is very critically ill patient, maybe the physician might consider to temporarily administer ARVs for at least 1 to 2 weeks. And the purpose of this is to reduce what is known as immune reconstitution inflammatory syndrome. Severe toxicity can also lead to, which is scheduled side effects, can also lead to brief modification of administration of these ARTs. We talked about prevention, very, very important, and we say that we have vaccines that are given to both males and female. So we have the Cervarix, that is one that is bivalent, targeting only the high risk, that is genotype 16 and 18. We have the Gardasil that is quadrivalent, it targets the 4 genotypes, that is the low risk, that is 6 genotype 6 and genotype 11. And also the one that targets high risk, that is the genotype 16 and genotype 18. We have the Gardasil that is nanovalent, that has 9 genotypes targeting, that is genotype 6, 11, 16, 18, 31, 33, 45, 52, and 58. It is important to know that 6 and 11 are the low risk, then the rest, as mentioned here, are high risk. So my take-home message is that both males and females indeed can be exposed to to HPV, and both males and females, we have vaccine that can be used. And there is need to create awareness and in terms of the infection that HPV can also affect males. It's good to get awareness that we have vaccines. It's good to get awareness that even the males who are already exposed to this can progress to a more severe form and can progress to what is known as the cancerous form, where one may present with anal cancer. With that, I would like to rest my case and open the floor for questions. If I was first, please allow me, you can tell me, then I repeat or I pardon. Back to you, moderator.
Thank you, Dr. Rogers. That was wonderful, and you were very audible, and your slides were clear. It was a very clear presentation, and I want to take this opportunity to invite questions or comments. Today we have some time. The presenter has taken a very moderate time, but I want to start with the questions that have already been asked. And if you feel you want to speak, you can just raise your hand. I will give you time. Ensure you have muted your background so that you are able to be audible to all of us. Again, if you've just raised your hand and you're not sure whether you've raised your hand, you can bring it down so that only those who have raised their hands can be given an opportunity to speak. So I will start with a question from Martin Jogona. Martin Jogona has asked 2 questions. I'll read both of them. So the first is, what are the common manifestation of HPV? And then he has asked also, can a child or infant acquire HPV during the birth process? And if it is possible, how long does it take for HPV to manifest? Doc?
Thank you. Thank you for that question. The signs and symptoms, one thing you should know that this is a very silent infection. Mostly the females are the ones who will come to the hospital for screening and also for checkups, unlike the males, okay? So just like any other viral infection, the HPV, the female will feel, it may start with some, it's a viral infection. One may have fever and all that, but there'll be some smell as well on the female part, but that doesn't mean that it is HPV, okay? So the symptoms can be asymptomatic initially, but over time, they may start manifesting. I may not know all of them offhand, but yes, I think that's what I can say. Then the next question was, sorry, the next question?
The next question from...
The same gentleman, he asked like 3 questions, I think.
Yes,
The first one was symptoms. The second one was on?
Yes, asked about, can a child or infant acquire HPV during birth process? And if so, how long does it take for HPV to manifest?
Okay, remember I said, let me start by saying my issue of manifestation. I said, if your immune system is good, the body is able to remove it from the system naturally, okay? That's why in my statement I said, HIV worsens this because when you are HIV and you are immunocompromised because of HIV, the body may not be able to remove this from the system, okay? Then in terms of incubation period, this will vary depending on an individual. We can't have a blanket time frame. Then mother to child transmission of HPV, no. Remember, infection is usually sexually transmitted. Okay. HPV is sexually transmitted, unless you talk about HIV.
Thank you.
Have I answered those two, three?
Yeah, that's clear. That's clear. So I think there are more questions. I just want to pick on the next
Please
one
go ahead. Please. I welcome questions.
from Gideon Motuku. Can anyone, regardless of age and gender, get the vaccine against HPV?
Yes, I did mention that we have vaccines, both for males and females. Usually they target 9 to 14 years before they get into active sexual exercise or sexual activity. We have vaccines that are given. If you look at what I've just projected, we have the Gardasil that is quadrivalent, that is protects against the 4 genotypes. We also have one that protects against the 9 genotypes. So vaccine, yes, can be given to both males and females.
Thank you. Ikemo Ngeno appreciates your presentation. It was great. What's the most explorable area of research in this type of cancer, especially on development of vaccines and other areas of diagnostics?
Thank you. Thank you for that question. I hope you're ideas, but let me just share with you. Currently, there's a PhD student who is developing AI to detect this order parameter, detect that is CIN1, CIN2, and CIN3. We have a PhD student who is developing that. It is AI generated so that when he does the colposcopy, the images he gets, there's something called machine learning, which is able to going to read this. It will do a scan on the picture and also confirm with the biopsy. So that is one area that is I know that there's a PhD student who is working on. Okay. Two, I also know some who are doing advanced research on sequencing. They're looking at the circulating strains that we have in this country for HPV and comparing it with what we have in the data bank. Some have done this already, but I know even National Public Health is working on it so that we're able to have that archived in the library so that we know this country. I also want to point out that it's very common. The common are in regions that have high HIV, that is around Western region. We experience high cases of HPV that causes cervical cancer in this region.
Thank you. That's well handled. Teresia Maluni, I hope your question has been answered on is the vaccine available for all age brackets? And
let me respond to that. Okay. Yeah, okay. Thank you for that. What usually happens before you get the vaccine, if in the event that you've had unprotected sex, you're not sure whether you've been exposed to HPV genotypes. Okay. So what you need to do first, regardless of age, you need to go for DNA testing, HPV genotyping, so to be able to establish whether you've been exposed to high risk or low risk. Remember, the HPV vaccines is able to protect against, in the event that you're only exposed to, maybe let's say you're exposed to genotype 16, you can get a vaccine that will give further protection against 18, 31, 45. So it doesn't matter. What you need to do first is to go for DNA testing to establish which genotype you've been exposed to, if at all you have, before you go for the vaccine. Over and back to you.
Thank you. I think you've just answered. There was the next one who was asking the routine test that can be done in males to ascertain if they have HPV. I think that's well answered. Chris Kunga is asking, can pap smear be done by untrained lab officers? Can HPV infection cause infertility in men?
Let me start with the first one. What do you mean by untrained? Because I want to believe once you've attained a diploma, you're already trained. Maybe what you mean is somebody who has gone for further training on maybe cytology and also histology. Is that what you mean? If that is what you're asking, yes, you can be trained this on the bench. One thing you should know about skills is all about interest. Skills is all about interest. It doesn't matter the basic qualification you have, provided you have, for instance, even if you have a first degree, even if you have a diploma, you can be trained on how to report the pap smears. It's just about having interest in that art. Okay. So I think I've answered that. The next question that he asked. Yes, the next question that he asked.
Can HPV infection cause infertility in men?
No, no, no. But if it progresses to cancerous state, I think first of all, you'll be very uncomfortable. If you look at the pictures that I've just projected, remember a cancerous tissue, and it will be gangrenous, but it doesn't affect your libido. I don't think it affects the spermatozoa, so it can't cause infertility. So once you've been exposed to the HPV, the genotypes, you'll continue spreading the infection. Okay, because in the event, I just want to put this into context. In the event that you are HIV positive and you are married, and let's say, God forbid, your wife has been confirmed to have cervical cancer. Okay, and that means that you haven't protected sex with her. It means that you also have genotypes that are high risk for cervical cancer. If you continue having unprotected sex with other females, then you're going to spread the genotypes that are high risk, and you're going to expose them to the same viral infection. I hope I've answered that.
Yeah, that's clear. I just want to go to the next one. I'm hoping that Ivy Akinyi, you want to say something? If not, you can have your hand down. But if you want to say something, just be ready. I'm going to unmute you and you make your comments. And allow me to read one from, this is anonymous. Okay, I think that has been answered. There's a question from John Wanyonyi. If a child develops anal warts and gets managed and no more warts develop during growth, when the child attains eligible age for vaccination, can he or she be vaccinated? Okay.
Thank you. The warts are usually associated with genotype 6 and 11. Remember, I said before you go for the vaccine, it's just good to establish whether you've been exposed to the genotypes that are shared with the HPV, shared with the low grade or the high risk. Okay, so it's just imperative that you need to go for the DNA testing first, so that you're able to establish whether you've been exposed or not. Okay, so I think that's how I can answer that question.
Handled. Kelvin Owino, if a patient has turned positive for one HPV subtype and negative for another subtype through PCR method, what action or advice do you give?
With regard to what? With regard to vaccine, whether he wants to take the vaccine or not, or with regard to... Remember I said that the fact that you've been exposed to the genotype doesn't mean that you'll develop cancer. The body has a way of removing it. It usually takes approximately 1 to 2 years. If your immune system is good, to be able to clear. But if there are other underlying risk factors, then this can create an enabling environment, and this can progress and worsens. But such a person, I think, needs to go for the vaccine. There's no harm in that. Remember, we talked about the various types of vaccine that exist and the types of genotype it protects you against.
Thank you. Vincent Korir, how often should one go for HPV screening?
Well, Vincent, I think, was my student. That was my student. I think the name is familiar. I know there are so many Vincent Korir, but the coincident. Okay, fine. What you need to do is that for those who are already exposed to HIV, they need to go for frequent screening for that. Okay, those already exposed to HIV are because of the risk associated with HIV, and they need to go for annual checkup. And there's algorithm for that. Let me just, I think I shared that on one of my presentation. But yes, I think for those who are not already engaged in sexual activity, I think it is good once you've gone for the pap smear. If it is negative, does not mean that you rule out that you don't have, you've not been exposed to the genotype. I think if finances allow, you can do the genotypic testing. Then if there's no presence of those either high risk or low risk, then you can go for the vaccine.
Catherine Bonde, if you can hear me, you can unmute and make your comment or remarks or question.
Yeah, so thank you very much, Fred, and thank you very much for the good presentation. I just have one concern and one question. To the presenter, which will be the ideal sample for the male when we are doing HPV? And then maybe I got it wrong where you were indicating that before the male are given the vaccine, they need to be done for maybe a DNA test. And looking at our resource setup, our diagnostic setup, I think currently the DNA tests are quite expensive. Are there plans from the national level that there'll be kind of assistance in terms of vaccination for the male?
Thank you.
Yeah, thank you. Thank you. Thank you for that question. Let me start by saying that in terms of testing, what I know is that there are some government hospitals that are able to do DNA testing by using of the Gene Expert machine. For those that are not able to do the DNA testing, I know that the national government is currently doing a surveillance on HPV. What they're doing is that they're able to collect both biopsies for the cervix and also the smears from via villi. There's a lot of that going on, surveillance in the whole country. You asked about the testing in males. You can use blood for DNA detection. And if it is the biopsies, then you can get it from the anal for those that you suspect. There has to be an indication for you to go for the biopsy. Remember, it's an invasive procedure. So for you to go that direction, then there has to be some indication. You don't just go invasive to obtain a tissue if there is no indication. I think there were two. Did you ask the third one? Vaccines. Yes, vaccines. Yeah, I think the government only has provision for females, and I'm not sure whether they also have for males in terms of free vaccination. But they're targeting, what I know is that they're targeting school-going children.
Okay, thank you. Ivy, you can go next. Ivy.
Thank you so much, Doc. I have loved your presentation, and I just wanted to add a point that seemingly you have also said that the HPV vaccine is currently for girls only between age 9 to 14. And the main reason that they are emphasizing on the girls is because we are making an assumption that a girl between the age of 9 and 14 has not had sex. So that's why our catch stage, our catch 22 is imagining that they've not had sex. Then another thing I also wanted to, which Doc has really explained, is how HIV makes us more susceptible to having HPV infection and cervical cancer. And just to add that there are behavioral changes, activities For example, in a study I think I read that was done in around Gobei and Jotiarech in Kisumu, it showed that those who have sex, like you're active sexually and you have multiple sex partners, then you're likely to have HPV infection. So that the study actually found that those who are, some of the people who are HIV positive, when you know that you have HIV, and the way Kenya currently has comprehensive care, then really you take care of yourself more than someone who doesn't have HIV. So indeed, while HIV is a risk factor, there is also the aspect of us having good sexual activity as a protective factor. Otherwise, thank you, Doc. I've enjoyed the slides and the images too. They're nice. Thank you.
Thank you, Ivy. Catherine Wangoi, you can go next.
Thank you. Thank you.
Catherine? She's not ready. Mostioki Mudeu, you can go next. Catherine, you can hear me now? Wangoi? Okay. Musyoki Mudeu, you can make your contribution. Musyoki? Musyoki? Okay. John Lokere, if you can hear me. Okay, ensure you raise your hand if you're ready. John Lokere. Okay. Charity Mugi. Charity. Charity. Okay. Enoch Korofia, a minute. Enoch. Enoch. Seems we'll go back to the Q&A again, so let me just read a few. The other question is from Monica Wangoi. What causes the HPV that causes zoster around the pubic area or around the mouth? Can it lead to cancer? Doc, if you can hear me.
I can hear you. I think what you're talking about is not HPV. The Monica is talking about a different viral infection. That's human herpes. Human herpes type 1 that is causing the oral sores. Totally different from HPV.
Thank you. And I'll read from Boniface on Sarigo. Kindly highlight on liquid-based cytology in cervical cancer diagnosis. Okay.
On Saringo, I have no answer to that.
Thank you. Dolly Mtinyari, what are the disposing factors of HPV and what are some of the precautions to follow to avoid HPV?
Yeah, you mentioned about precautions. One of them is make sure that you have protected sex. Go for the vaccine, if that's what you're asking for. But we also have other what possesses a risk factor. There's something called risk factor. For like the lady just alluded, multiple sexual partner puts you at risk. More so if you have unprotected sex with multiple sex partner, that can put you at risk. Among the females again, for cervical cancer, those who tend to smoke also has been shown to be a risk factor.
Thank you. Victor Kibet appreciates the presentation and asks, mine is about diagnostics and sensitivity and preference between HPV and pap smear. Which is the preferred test for diagnosis in any age group?
Yeah, so maybe for the avoidance of doubt, the gold standard for diagnosis of cervical cancer is biopsy. There's a difference between cervical cancer and the genotype that causes it. The DNA testing just established the presence or absence of the genotype that is associated with the cervical cancer. And I've said that for you to establish whether one has cervical cancer or anal cancer, then you need to do a biopsy. The genotyping just tells you the presence or absence of the genotypes that are associated with this cancer. And I said, the fact that you have the genotype doesn't mean that you'll develop the cancer.
Vitalis Were, is there any relationship between HPV and Kaposi sarcoma?
The host, can you take control of those who are talking so that I'm able to address that? Those are totally different viruses. Kaposi sarcoma is human herpes, type 8, totally different and from human papillomavirus. So those are totally different viruses, though both of them are DNA, but they're totally different viruses.
Thank you. There are still a few more questions. Maybe
Go ahead.
I'll read from Enoch Sang. Please repeat the difference between oncogenic and non-oncogenic.
Okay, good. Let me take you to the first slide so that you appreciate that. So we know that there are different genotypes. Let me take you to the last slide where I talked about the vaccines. We have different genotypes that are associated with HPV. The genotype 6 and 11 is one associated with the low grade or low risk. It's known to cause the warts, okay? And this is non-oncogenic in form. The genotype 16, 18, 31, 33 are associated with high risk, and these are known to be oncogenic types, okay? The 6 and 11, more common in males, but can also be found in females, especially for those males who like having anal sex with females.
Thank you. Justin Getonto, in matters of policy and Vision 2030, is there a focus on HPV? If yes, does it include testing? If no, are virology scholars engaging the government? I think
yes.
Yes.
Yes, I mentioned that currently there's a national surveillance going on for HPV. In fact, it's a countrywide. The first screening test they do is via VILI. There are some facilities that will do the VIA, some will do the VILI. And I said this is a screening test usually done by the nurses. It's a presumptive test just to detect the presence of abnormal cells. Okay. Once the VIA VILI has been confirmed to be positive, again, the government has foot soldiers where they do both the pap smear and the biopsies. I think this is taken to national government where they do genotyping. And also, I think, I'm not sure whether they have now started doing the sequencing, but I know they do the genotyping.
Thank you. Kevin Onyango, are there in vitro lab rapid tests for HPV? If so, what's the preferred sample type?
Yeah, so for remote and resource limited facilities, VIA is among the cheapest, and it's a very simple procedure. It takes around 4 to 5 minutes, and you have your results. It's just a screening test. It just tells you whether it's presence of abnormal cells or not. The nurses. So it's just a presumptive test. It's not a confirmatory test. Then we have the pap smear as well that can be reported by cytologists. Again, this is not a confirmatory test. It's not the gold standard. The gold standard, again, I repeat, is the biopsies that involve the cervical tissues that are obtained.
Thank you. John Lokere, if you can hear us, you can unmute and make your comment. John? John Lokere? Okay. Charity Mugi, are you able to speak now? Charity, you can unmute and make your comment. Okay.
Thanks a lot. Hello.
Yes,
welcome.
proceed.
We can hear you.
Yes.
Go ahead.
Okay, thanks a lot. Mine is to appreciate the doctor and the management as a whole. Thanks a lot. God bless.
Oh, thank you, thank you, thank you. God bless you too.
So, Dr. Norman, there are a couple of questions. Maybe I can just read.
Please read.
From this is Marion Nyagodhie. Which vaccine is being administered to girls in Kenya currently? And then Martin Joguna has asked, can you kindly clarify the most, okay, I don't know what you wanted to say. Can you clarify
Just
the most
read it.
cancer?
Just read the way it is. We'll correct him. You know, this is a learning platform. Just read the way it is. We'll correct
The
him.
most genotype. I think that's what you wanted to say.
Sorry, did you say the most what?
Clarify the most cancer-caused genotypes. That's what he has written.
Okay. So the first question was the current the thing the lady asked, which vaccine is currently being given. I'm not sure with the one that the government is giving, but what I've projected is that we have those that targets only the high risk, that is the genotype 16 and 18, the bivalent Savarix. We also have the Gardasil that protects against the 4 genotypes, that is the low risk, which is 6 and 11, and also the high risk 16 and 18. You're asking that which is the question from the gentleman. You're trying to ask about the risk in terms of cervical cancer. I think the question is 16 and 18. Those are the high risk genotypes that are known to associated with the cervical cancer.
Thank you. And Jerop, what can explain the cervical cancer cases on all patients who are not sexually active or the virus remained latent for a long period of time?
So what was the question? I think this is somebody who already maybe was exposed to it. If you're not sexually active, maybe you've already been exposed. Maybe you already had a sexually unprotected sex first time, and after that you went to a dry spell for maybe a long time and already exposed to the virus. So what will happen in that the body, if the body is not able to remove it from the system, it's going to be in a latent state until that time that maybe for one reason or another you become immunocompromised, or because of that persistence, it progresses. I think I've answered that. Can the host take care of those who are talking?
Okay. Asigo Okoth David, what is the professional advice to a couple who wants to marry where the man lost his wife due to cervical cancer? At what age should men start getting HPV vaccine?
Well, if you already know that the wife died of cervical cancer, and these are people who have been living together maybe for more than 1 year, and they were having most likely they were having unprotected sex, there's high likelihood that this man already has the genotypes that can cause cervical cancer. I think it will just be prudent for the lady to maybe go for the vaccine before. That is one. Two, those are, I don't know, those I find that a bit very sensitive. I think let the lady go for counseling. I may not be in a position to, with this kind of knowledge, I think once you expose the person to the knowledge, then you let them make an informed choice. I may not decide for the lady for now. But there's high likelihood that the man still will continue spreading those genotypes even to a new partner.
Okay.
Yes. What was the other question from the same lady? I think she had two, and I might have responded to one.
Okay, maybe I'll find it, but maybe you can go to this. Stephen Kiumba, can HPV cause oral cancer for those who engage to oral sex?
I think I pointed it out. Let me just take you to the slide. Maybe it was not keen. We talk about the oropharyngeal cancer. Okay. You've seen that on my presentation here. Are you able to see it? The cursor I'm pointing?
Yes,
We can move to the next question.
I can bring a question from. Okay. Migunde Collins, can HPV cause problems during pregnancy? And then maybe I can add this also one from Feliciana Kimani. Is there a relationship between HPV and breast cancer? I mean, can someone with breast cancer spread HPV?
Those are totally different. Remember, those are totally different. The HPV, the cervical cancer is caused by the HPV. Breast cancer is totally different. Those are two different types of cancer. There's no relationship between those two.
Thank you. Dr. Kefas, thank you for the question. KI67 gene, is it involved in cervical cancer progression?
Diagnostic. It helps to clear those pap smear that are borderline. And also it can be used as a diagnostic marker for cervical interepithelial neoplasia, that is grade 2 and grade 3.
Thank you. Riga Natuta, comment on the distribution of HPV types based on geographical location and perhaps by race. Are there any variations in distribution of the HR types? Which high-risk types are most prevalent in Kenya or in sub-Saharan Africa?
Well, I think 16 and 18, like the one I've mentioned, and I did mention that it's very high in Lake region because of HIV. The high HIV prevalence. We've also seen high cases of cervical cancer or the genotypes that associated with cervical cancer in that region. And I said that currently the government is also doing a surveillance on that. I think it's a countrywide. So I think with that, I think that is sufficient response from me.
Thank you. Jafet Kemboy, I think we should, can a person who has been vaccinated or treated against HPV be able to transmit it? Again, is there a relapse of HPV after treatment?
Well, it will depend with the kind of treatment you're talking about. Because you see, once you've been diagnosed, whether it's a CIN1, CIN2, there is need for follow-up to see if it is progressing or not. Okay, and remember I said CIN1 is not cancer. CIN3, despite the fact that it's a severe form of dysplasia, doesn't mean that one has the cervical cancer. So I think what it needs to establish, if one has been confirmed to be cancer, there are certain treatments that one has to undergo. So
Okay.
let me just repeat this part for the avoidance of doubt, based on just projected. This order parameter will help us to establish the progression. We have the CIN1, CIN2, CIN3. Even the 3 does not confirm that one has cancer. It's just a more severe form of dysplasia. In the event that it breaches this basement membrane, then this is an invasive form. Then this is a confirmatory that that individual indeed has the cancer. And this can spread to the vagina, can spread to the bladder, can spread to the uterus.
Okay, thank you. Winfred Njeri.
I also say that the treatment are different. The way a gynecologist or the physician will treat or the oncologist will treat the CIN1, the treatment modalities are different.
Thank you. Winfred Njeri, is there a correlation between individual genetics and HPV infection progression to cancer?
Yeah, we talked about. I think the most important thing is for progression to occur, we have what we know as the risk factors. I mentioned about exposure to HIV can also be a risk factor. And how is that? Remember, HIV suppresses your immune system. until to a level that you might become immunocompromised if you don't take ARVs. So that will enable an environment for the virus HPV genotypes to persist in the system and also enhances that progression. So another risk factor also is smoking, especially among the females, has also been attributed to be a risk factor for that.
Thank you. I think we are almost there. Rashid Osman Isaac, considering the limitations of cytology in immunocompromised patients, how can molecular diagnostics such as HPV DNA genotyping and P116 and KI67 dual staining enhance the sensitivity and specificity of HPV-related lesion detection in advanced HIV cases? Also, what are the challenges in integrating these assays in low resource lab settings?
Sorry, I lost you at some point. I only had you mentioning about the cytology.
Considering the limitations of cytology in immunocompromised patients, how can molecular diagnostics such as HPV DNA genotyping and P16, KI67 dual staining enhance the sensitivity and specificity of HPV-related lesion detection in advanced HIV cases? Also, what are the challenges in integrating these assays in low-resource lab settings?
Yeah. So let me answer that. One thing that my colleague is asking, in low-resource setting, the government has put in place the VIA-VILI test. And I mentioned that this is a very simple test, mostly done by nurses. It takes around 5 minutes and you have your results. It gives you a presumptive diagnosis, whether it's the presence or absence of abnormal cells. I also want just to reinforce and or to echo this, let this come out clearly. There's a difference between having genotypes that are high risk and one to be confirmed to have cervical cancer. The only way to confirm the cervical cancer is by biopsy. Okay. One could be having the genotypes 16 and 18, which are high risk, but doesn't mean that that individual has the cervical cancer. So the genotyping will tell us whether one has been exposed to the genotypes, whether it's high risk or not. But the only way to establish whether one has cervical cancer is by use of a biopsy. Not even the cytology pap smear will confirm that. But again, for resource-limited facilities, if they're not able to do pap smear, then they should be able to do the VIA-VILI.
Thank you. I think with that, colleagues, we have come to the very end of today's webinar. It has been very informative, very interactive, and we really appreciate for your time and your participation. We also want to take this opportunity to thank Dr. Rogers Norman for taking his time and also for being patient with all the questions that have been asked. I want to give him this minute to maybe say his closing words. I'll make a few announcements and then we shall just bring this to a close.
Thank you. But the host, you put my video off, so my participants were not able to see me despite being in the dark. I don't know what you did, but my video is not on. My hosts need to see me and appreciate who is talking to them.
George, can you have his video on for a minute?
Yeah, so members and colleagues in the profession, I'm very humbled and I want to thank you all for finding time to join this session. I can see some comments from my former students. Thank you so much. I want to indicate that in Kisumu and where I live, we are currently having blackout. So I mean, it might be very clear, but it was a pleasure and honor to do this webinar presentation. And it is my hope that it was very insightful. And I want to encourage my colleagues in the profession, please spread the awareness regarding the vaccine that is available. We need to protect both males and females. We need scientists who should take up the mantle and do research in these areas, not only HPV, not only HIV. There's so many viruses. Most times when I interact with people, they tend to say that virology is a small area. I think they have not, they may not know, but there are so many viruses that one can study or one can have interest in that is known to be a public health concern. Not only HPV, not only HIV, we have quite a number. And I want to encourage again students and also, sorry, you are now my colleagues. Please, I've shared the presentation, and if you want the PowerPoint, you can get it from the host. You can contact me directly if you want. I'm based in Maseno University. I value mentorship more so for colleagues who are interested in advancing their areas of profession. I'm very passionate about that. And also want to thank the host for giving me opportunity to do this presentation. I don't take that for granted. Back to you, moderator.
Thank you, Dr. Rogers. Indeed, you can read the comments, a couple of them. Everyone is saying they enjoyed the presentation. It was insightful, well-researched, and wonderfully executed. From us, the Lab Medicine Society of Kenya, we are very much happy for, accepting our invite on this platform. And I can see you have many students. You have mentored them from KMTC, KISS University, and now at Maseno University. We are very glad for the good work that you're doing and even for your willingness to continue doing the mentorship. And I want to invite everyone who may be in need of Dr. Norman's number. We are open. You can just ask for it. This presentation, as always, will be shared on the WhatsApp group. If you're not in our WhatsApp group, you can join. I shared the link there. And at this point, I just want to announce that your certificates will start streaming in immediately after this webinar. But if you don't receive it, don't panic until after 3 days. Then you can be able to raise your concerns. Otherwise, from us, if you had challenges logging into Zoom and you just watched us through YouTube, just reach out to us because we don't award CPD through YouTube. But if you had the challenges in the next, maybe before you sleep, ensure you reach out that you are following through YouTube so that you can see how we can assist you. For those of you who will want to make reference, you can go to YouTube and search our channel. You shall find this presentation there. It was live. And I think with that, I want to take this opportunity to say, on behalf of the Lab Medicine Society of Kenya, asanteni sana, and see you in our next webinar. Thank you and good night.